Good afternoon, everyone. Welcome to today's session in this Women's Wellbeing Lecture Series, hosted by the GW Resiliency and Wellbeing Center. I'm Lee Frame, Chief Wellness Officer for GW Medicine and Director of the Resiliency and Wellbeing Center. This lecture series is supported by the Rosemary Bowes PhD Women's Mental Health Fund and aims to advance whole person health for women by addressing the intersections of physical, emotional, and mental well-being. Today, we are honored to welcome back Dr. John Neustadt, ND, a nationally recognized expert in integrative medicine and bone health. Dr. Neustadt is the author of Fracture Proof Your Bones, a comprehensive guide to osteoporosis, and his work emphasizes evidence-based root cause approaches to prevent fractures and improve skeletal health. He's published more than 100 research reviews, served as an editor of a textbook, and authored 4 books. Dr. Neustadt earned his naturopathic medical degree from Bastyr University, where he was honored with the Founders Award for Academic and Clinical Excellence. He went on to found Montana Integrative Medicine, a clinic dedicated to treating chronic, complex conditions through a personalized integrative lens. As part of this series, Dr. Neustadt previously presented Supporting Women's Bone Health, which is now available on demand on our website, including presentation slides and the full recording. We are also pleased to announce that he will be returning on September 19th, 2025, for another talk in this series entitled Ultra-Processed Foods, Health Implications and How to Talk to Patients. That session will take place again from noon to 1 Eastern Time via Zoom, and registration is open now on our website. For today's presentation, Dr. Neustadt's going to be presenting the gut-bone connection in women's health, where he's going to explore the emerging science linking gastrointestinal health to bone density, hormonal balance, and chronic disease risk. Please join me in welcoming Dr. John Neustadt.
Thank you for that gracious introduction. I'm honored and really happy to be here for another round of presenting on this topic of bone health, because it's something that I've been researching and involved with for 2 decades now. I'm very passionate about because unfortunately it is an under-recognized issue. In fact, only 5% of Medicare eligible patients are getting screened for osteoporosis with a bone density test. So one of the big messages that I have and that I continue to speak about and lecture on is get screened and understand the risks, because there are many other risks besides just age and the decrease in estrogen that comes with menopause for women. And in fact, in women with osteoporosis, postmenopausal women with osteoporosis, up to 30% of those cases are due to other things besides just the decrease in estrogen. And in male osteoporosis, which accounts for about 20% of all cases, the decrease in testosterone that can accompany aging in men is a cause for osteoporosis, but up to 60% of those cases in men also have other factors involved. And one of the under-recognized contributors for osteoporosis is this gut-bone connection, or what I call enteropathic osteoporosis. So we're going to talk about that today. Those are my disclosures. All the research citations for anybody who's interested in research are in here. I have all the PDFs, but I do have a dietary supplement company. I started it out of my medical practice that was mentioned in the introduction almost 20 years ago now, when I could not find the doses of nutrients shown in clinical trials to work that I needed for my patients. And I do have some products for bone health. So I just want people to understand that so they can make their own conclusions based on the research and what I present. And then some of my other involvements. I'm on the corporate advisory roundtable for the Bone Health and Osteoporosis Foundation. That is an uncompensated position. There's my book if anybody's interested in learning more. It walks people through how to create holistic bone health plans that make sense for them and gives them questions to ask their physicians to make sure they're getting the best possible recommendations for their diagnosis and health history. So what do we have here? What is osteoporosis? Essentially, it's a condition of imbalance where the destructive forces are winning and bone is being destroyed, which predisposes and increases people's risk for fractures. And in fact, if you're a woman with osteoporosis who breaks a bone, who breaks a hip, there's up to a 36% chance that you're going to be dead within a year. The most often cited figure is 20% in the research, which is still greater than the risk of dying from breast cancer for women 65 and older when all the stages of breast cancer are combined. I'll get more into a little bit of those statistics in a couple of slides, but what I want to demonstrate here is the different factors as they relate to gastrointestinal health and how they influence bone. There are two primary metabolically active cells in bone. The osteoblasts build up new healthy bone, and it's not just the bone minerals that they help deposit into bone, but they also produce bone collagen and that extracellular matrix that is so important to bone strength and overall bone health. And in fact, there are 180 to 200 different proteins in bone in addition to collagen. So what's going on with osteoporosis is the other type of major metabolically active cell, the osteoclast, is outperforming and outcompeting the osteoblast. The osteoclast breaks down old worn out bone in a process that is called bone remodeling, where old bone is broken down and new bone is created by the osteoblasts. And when the osteoclasts are outperforming and doing more damage than the osteoblasts are healing, then you've got bone loss, osteoporosis, and increased risk of fractures. And with respect to enteropathic or the gut-bone connection, medications, chronic inflammation, immune system molecules called cytokines, interleukins, nutritional deficiencies, a dysbiosis in the gut, hormonal imbalances, and leaky gut, all are contributing to this situation. And our job is to try and rebalance this system. Can we identify the risks? Can we stop or minimize the risks if you're on a medication, for example, that is causing bone loss and increasing your fracture risk? Is there a way to decrease that dose or perhaps switch to a different medication that is safer? Or ideally, if you can discontinue that medication and it's safe to do so and appropriate to do so, then of course that would be the best situation. And then we want to increase and do the things that we know are healthy, that improve bone density, that maintain bone strength, and that reduce fracture risk. So there's the fracture risk and mortality. The hip fracture mortality risk from a hip fracture is greater from breast cancer, as I mentioned, and the greatest risk of dying is within the first 90 days. So if somebody does survive that, they have a greater likelihood that they're going to survive, for that 12 months. But what happens is when somebody fractures, it can start this downward spiral. And I'm talking specifically of a hip fracture, of problems where they are more sedentary, so they can get a loss of muscle weakness, imbalance. 95% of fractures occur because somebody falls. So that imbalance and the risk for falling is an important risk to try and decrease. Being sedentary after a fracture increases that risk for muscle loss and muscle wasting. It also increases the risk because somebody could have a decrease in appetite, which could be due to the inflammation from the fracture, from just being, depressed or sad that this has happened to them, and so their appetite might go down. So they can be at increased risk for additional nutritional deficiencies on top of what they might already have. And then, of course, if they're sedentary, if they're hospitalized and they're not ventilating fully in terms of breathing and increasing the respiratory rate, it does increase the risk for pulmonary lung infections. And so all of these things and others are really dangerous situations. And of course, we want to avoid to begin with. Patients with liver cirrhosis undergoing a total hip arthroplasty, there's a 60% mortality in those patients, and 80% more morbidity. So those are patients with osteoporosis. So PMO at the top stands for postmenopausal osteoporosis. If a patient with liver cirrhosis with osteoporosis goes through a total hip arthroplasty, there's a very high chance of them dying. And if you have breast cancer and are hospitalized with a fracture, there's an 83% increased risk of dying compared to somebody who without breast cancer who is not fractured. And when it looks at gastrointestinal conditions, I like summary tables. So this summarizes quite a few GI conditions and compares them with a quick glance with other types of postmenopausal osteoporosis here at the top. So in general, at the very top, let me get a pointer here. I think I can do a laser pointer. There we go. So at the top, adults 50 years and older. In general, you're talking about 20% of women, approximately, and this is in the United States, have osteoporosis. About 43%, however, have some bone loss. It's just not meeting that criteria yet of osteoporosis, which is a T-score of minus 2.5 or lower. And with men, about a 4.4 osteoporosis prevalence risk. But what you have here in terms of fractures for women without these GI conditions, just in general, that a woman's lifetime risk for fracture is 40%. When somebody and for some of these conditions, there aren't fracture data, and fractures are the most dangerous thing. Bone mineral density is the gold standard for diagnosis, screening, and monitoring treatment, but it has its limitations when it comes to predicting fractures. So please be aware of that. A bone density test only predicts 44% of women with osteoporosis who will break a bone and only 21% of men. So fracture risk depends on factors largely other than bone density. And balance, as I mentioned, risk for falls is a major risk factor. And so bone density is one thing we want to look at when looking and evaluating more holistically and trying to reduce somebody's risk of fractures as much as possible. That bone density test is one of the variables that's important to take a look at. So for celiac disease, up to 60% of low bone mineral density and 35% osteoporosis. Gastric bypass surgery, after about 7.5 years, there's a relative risk of 2.3 times of getting a fracture. That's 230% increased risk of fractures compared to somebody without the gastric bypass surgery. After 15 years, 58% fracture incident. I mean, 58% of those patients are fracturing compared to 24% of the control group, those who have not had gastric bypass. And hopefully with GLP-1 medications, the need for gastric bypass surgery is dropping off and decreasing. But there are a lot of people who have had gastric bypass surgery. Every patient I've ever spoken to who's come to me, who has already had this procedure done, their physician has never talked to them about osteoporosis, never talked to them about nutritional deficiencies, and oftentimes is not even recommending they're on a multivitamin supplement or providing them with some nutritional recommendations or support along those lines. Acid reflux, gastroesophageal reflux disorder, or GERD, taking proton pump inhibitors, those are like Protonix, Prilosec. The first FDA warning letter showing that those decrease a damaged bone and increase the risk of fractures was sent out by the FDA in 2010. So this is not new information. And what we do know is that the risk for hip fractures with long-term PPI use, that's taking it for years. And in general, for acid reflux, or not in general, for acid reflux, taking PPIs has never been approved by the FDA for longer than, I believe it's 6 weeks. And yet people are taking these for years. They're available over the counter now as well. There's a 350% increase risk of of fracturing a hip if somebody's on long-term PPIs. And 50% of all proton pump inhibitor prescriptions are for acid reflux, just that one condition. So it's something I'm very concerned about, especially because we know that dietary modifications alone can help a lot of people not experience acid reflux. And there are other ways from an integrative medicine perspective to evaluate and treat acid reflux that can allow people to avoid having to take proton pump inhibitors or other acid blocking medications like an histamine 2 receptor antagonist. For IBD, there's a 41% increased risk with people with ulcerative colitis for fractures compared to those without IBD, and 68% for Crohn's disease compared to people without Crohn's disease. And you can see all of these, going down the list. Even irritable bowel syndrome, 27% increased relative risk of fractures compared to people without IBS. Those are all the citations if anyone wants to dig in further. So the primary mechanisms for gut-induced or the gut bone connection, enteropathic osteoporosis, gut induced bone loss, medications, so glucocorticoids, antidepressants, SSRIs, SNRIs. What we know now that there are serotonin receptors in bone. About 24% of women over, I think it's 64, 65 years old, are taking an SSRI. They're already in the prime group for bone loss and osteoporosis. And many people who have these chronic conditions, GI conditions, are going to be on an SSRI. It's the most commonly prescribed antidepressant medication. And there are serotonin receptors in bone. They activate osteoclasts that break down bone. And now we know from meta-analysis that for every 19 women taking, or every 19 patients taking an SSRI for 1 to 5 years, that we expect one of them to break a bone. So it's a situation that's very serious and should be taken seriously. And then also medications, PPIs. I'll dive a little bit more into the research in a bit. For prednisone, glucocorticoids like prednisone, powerful anti-inflammatories, 1 to 2% of the general population are on long-term glucocorticoids, and they are powerful bone destroyers. The risk for fractures and the risk for bone loss appears in people taking these glucocorticoids before it even shows up on a bone density test. So it's important to be aware of that. And even with short-term glucocorticoid use, bone loss has been documented. Immunoporosis, or immune system activation. Immunoporosis is a term that was recently coined by a researcher, and it's a combination of immune activation and osteoporosis. And it's the chronic inflammation I mentioned before, and those increase the activation of osteoclasts that break down more bone. And also you have signaling directly interacting from the bone, from the gut, that travels to the bone and activates osteoclasts as well. Nutritional deficiencies, dysbiosis, some of that microbial bullet point down here, dysbiosis, and then endocrine hormones or hormone-like molecules that interrupt with proper bone signaling and bone health. I'm going to go through a few diseases in a bit of detail here. Celiac disease, importantly, when some patients are worked up and there is no real, understood or identified mechanism by which they have, gotten osteoporosis or bone loss, meaning they haven't been able to identify a secondary cause, then celiac disease should be evaluated, because sometimes celiac has been documented for being the only symptom, meaning there are no other symptoms of osteoporosis. And that can be a sole presentation of celiac disease as well. So celiac disease can cause osteoporosis, and celiac disease can be silent, meaning there are no symptoms outwardly of celiac disease, except if somebody's diagnosed with osteoporosis, the celiac disease can be causing that. And that's because of that inflammation, the chronic inflammation, decreasing calcium absorption, increased osteoclast activation. And then there are many other nutrients, vitamins that have been, and minerals deficiencies that are common in celiac disease, like iron deficiency, folic acid, vitamin B6, vitamin D, copper, and zinc. And all of those are important for not only overall health, but bone health specifically. For people who are newly diagnosed patients, 15 to 35 years old, up to 60% have low bone mineral density, up to 35% have osteoporosis. Data in younger men and younger patients is lacking. Once they go for pediatric patients on with celiac disease, when they go on a gluten-free diet, the bone density does increase, and it can increase in older patients as well. It's more likely, though, to return in normal in children on a gluten-free diet than in older age groups. Primary biliary cholangitis, not a common condition. And the optimal strategy, though, when somebody has it in terms of bone loss, is not well defined. And one of the challenges in the research and that we're confronted with clinically now in terms of just making the best judgment that we can in terms of treatment options is when we're looking at medications and possibly using medications, the vast majority of the clinical trials on those medications have been done on postmenopausal women with osteoporosis, not in these other secondary causes. And the mechanism of actions by which the drop in estrogen affects bone and decreases bone density, decreases collagen production, and increases osteoporosis and fracture risk is quite different from the mechanisms of actions of all these other secondary causes that I've mentioned so far, including the medications. So the assumption that, well, we are going to take a medication that has been used for postmenopausal women with osteoporosis, and we're just going to prescribe it in all of these other cases of osteoporosis too, has shown to have some mixed results, meaning it's when the research is finally done, it's not always shown to be beneficial. For example, if somebody is on a proton pump inhibitor and they then take Fosamax or one of the oral bisphosphonates, the research has shown that the risk for fractures in people who are taking a proton pump inhibitor plus a bisphosphonate is 52% higher than somebody who's just taking the bisphosphonate alone. And so it's important to be aware of that we basically are educated and are educating our patients so that they can make the best possible informed choice, informed decisions. And what we see here with PBC is that the majority of data on the medications, are extrapolated from postmenopausal women with osteoporosis, and the most recent recommendations were from 2009 in the American Association for the Study of Liver Disease, and they're recommending Fosamax based on that postmenopausal osteoporosis literature. But a 2020 review article that looked at the studies and looked at a pooled analysis of bisphosphonates did not demonstrate any improvement in bone mineral density compared to placebo, or just doing nothing. Overall, the quality of the current evidence is low. Hence, the use of bisphosphonates in primary biliary cholangitis still requires further investigation. There are some clinical trials using a nutrient called MK4. It's a specific form of vitamin K2. There are different forms of vitamin K2. This specific form of vitamin K2 is the only one shown to improve bone density and maintain bone strength, as shown by fewer fractures in clinical trials. And the clinical trials that showed fracture reduction were in postmenopausal women with osteoporosis using 45 milligrams per day. And this 45 milligrams per day of MK4 has also been used in other conditions, including PBC. And what they did is they gave this nutrient for 24 months. And what they saw is at the end of 12 months, the MK4, those taking the MK4, basically their bone density was stable, and those not taking it had a loss of 3.5% in people not getting that nutrient. 2 years later, the bone density did decrease somewhat in the MK4 group. It definitely slowed the bone loss, compared to the primary biliary cirrhosis group of patients who did not get that nutrient. They had a nearly 7%, so double the bone loss that they had at 12 months. They experienced then at 24 months. People who have stomach cancer, if they have a gastrectomy, that surgery, you get osteoporosis fractures occurred in one study, a median of about 3 years after the procedure. And what you're looking at here is a large study that tracked over 5,000 patients who fractured, and 780 of those had multi-site fractures. So it's not just one fracture. 15% after the median of 3-year follow-up had fractures in the elderly and in chemotherapy patients. So some of the risks, and to understand, because this is really a multifactorial analysis, the risk for osteoporosis and fracture, rarely comes down to just one thing. Older age, we can't change our age. That's a non-modifiable risk factor. That's associated with the increased risk in this patient population. Just being a female also increases the risk. Having a total gastrectomy versus partial increases it somewhat. And then significantly associated with fractures, other conditions like diabetes, and also taking chemotherapy. So if somebody is looking and trying to understand the overall risk, understanding and combining the different risks can help identify, what we can change, what we might be able to intervene with, and what might be more challenging. The American Gastrointestinal Association 2003 recommendation, it's the most recent recommendation for people with a gastrectomy, should get a bone mineral density measurement or calcium or bisphosphonate supplement after at least 10 years. Now, I think that is too conservative. I think people should get a baseline bone density test before the surgery, and then after perhaps 12 to 24 months after, to see what's going on. And if there's already a trend towards bone loss, because remember the median time to fracture after this procedure was 3 years. So waiting for 10 years, I think is missing the opportunities to identify patients at risk and help them sooner. In terms of bariatric surgeries, you've got in 2022, there are 280,000 of these surgeries performed. So this is a large patient population that is largely not being evaluated and not being assessed for bone loss, osteoporosis, and fracture risk. So hopefully raising the awareness of this issue will get more people screened. And what you see also in terms of bone loss, 1 year after just bariatric surgery, in general, I'm not talking about post gastrectomy, talking about bone loss after bariatric surgery, whether it's a sleeve gastrectomy or a Roux-en-Y procedure or gastric banding. 71% had vitamin D deficiency, and that's a vitamin D level of lower than 30. I am an advocate and believe that people should get their vitamin D levels tested. The blood level or serum level of vitamin D that is associated with a maximum hip fracture reduction is 30 to 44 nanograms per milliliter. And so that's what I advocate for. People get at least that. I know there are clinicians out there and research supporting higher amounts for immune support, but just for bone health and fracture reduction risk, getting into that 30 to 44 nanograms per milliliter range is going to give you the maximum hip fracture reduction, or is associated with the maximum reduction in hip fracture risk. Iron, also quite prevalent in terms of iron deficiency. Almost 22% of patients just 1 year after this procedure have low serum ferritin. Ferritin is a storage form of iron. It's the most sensitive indicator for iron insufficiency and iron deficiency. It shows up before you see decreases in red blood cells, hemoglobin, and hematocrit on a red blood cell test. You also see that ferritin, the reference range is so broad as to be clinically irrelevant and very challenging for clinicians to know what to do with. I've seen as low as 10 to over 200, and anything in that being normal. My goal for patients is they're up around 60 or 70 in terms of a serum ferritin, because iron is used for so many things in the body, not just within red blood cells. Vitamin B12 deficiency, folic acid, vitamin E, vitamin A, zinc, copper, and selenium, all there, all in the research. So a good multivitamin that is well absorbed is important. One of the challenges with dietary supplements is the form in which the minerals come in. So if they are if they come in the oxide form, it requires a low pH of stomach acid. So depending on the type of bariatric surgery or the type of intervention that changes the anatomy of the stomach, hydrochloric acid might be decreased. So the pH of the stomach might be higher. And so getting an amino acid chelated mineral, a multivitamin, if you look at a multivitamin and you look at the copper, zinc, magnesium, and any of them say oxide, it's not the highest absorbable forms. You want to look for citrate, malate, taurate, gluconate, amino acid chelate. Any of those forms are much more absorbable. And the citrate form, for example, with calcium citrate versus calcium carbonate, is up to 23% more absorbable with just normal stomach acid, and even better absorption when stomach acid is low. And then my preference with folic acid and vitamin B12 is to look for the methylated forms. That would be methylfolate and methylcobalamin, because those are the biologically active forms of those nutrients. And some people have a genetic mutation in MTHFR, genetic polymorphism, that makes it difficult, if not impossible, for them to methylate other forms of the folic acid and vitamin B12, just so their body, their biochemistry can use it. Bariatric, and if anybody's interested on my website, there is an article on there on how to evaluate dietary supplements. Make sure you're getting your money's worth. That talks about all of this. So the clinical guidelines for bariatric surgery, there's no data on the use of the anti-resorptive agents. So Fosamax, Zometa, any of those bisphosphonates for the management of bone loss. So just be aware of that. You're looking for secondary hyperparathyroidism, low calcium, low vitamin D. Those are the general recommendations. But as you saw in the data that I just showed, there are other things that I think need to be taken into consideration and evaluated. You can run a serum ferritin test. You can do a urinary organic acids test to look for vitamin B vitamin deficiencies. You can test vitamin D. You can do serum levels of B vitamins as well. There are different ways to test and evaluate somebody's vitamin and mineral statuses. The gold standard for testing for minerals, except for calcium, but for all other minerals, is a intracellular mineral test, like a red blood cell minerals test. That's the gold standard in nutritional medicine for identifying if somebody has enough of those. Irritable bowel disease and bone loss, it may be the primary sign or the predominant sign in children and adults. Again, you may not have those gastrointestinal overt signs or symptoms going on. And the principal mechanisms behind the reduced bone mineral density, not completely understood. And it's a complex network of those inflammatory molecules, those immune molecules or cytokines that influence the bone destruction. That's been reported. But there's also dysbiosis involved that can be common in patients with IBD. But there are other factors like medications, the prednisone, glucocorticoids I mentioned, nutritional deficiencies, the gut bone signaling in terms of molecules, multiple intestinal resections, so if they've had multiple surgeries, and then again, that microbiota, that dysbiosis interactions with the gut. Prednisone, glucocorticoids, dexamethasone, 22 to 77%, depending on the study, are taking, have a history of taking corticosteroids. The risk of osteoporosis fractures is 132% increased risk compared to patients without irritable bowel disease. And the risk of a hip fracture, 141% increased risk for patients with ulcerative colitis and 168% for Crohn's disease patients. Now, if they're on steroids, the current use of steroids accounts for a 35% reversible increased risk for fractures. So if we're able to get somebody off of the corticosteroid, that can help reduce their risk of fractures. And also if they're on an opioid prescription, that also gives a dramatic increase in their risk for fractures. And part of that is because of the risk of falls. Again, nutritional deficiencies, similar to bariatric surgery. You get nutritional deficiencies with irritable bowel disease. IBD patients have been shown to be low in vitamin K. And like I mentioned before, that MK4 form of vitamin K is crucial for bone health. And in fact, that form of vitamin K is the only form our bodies can synthesize. There's a pathway in our biochemistry. There's a similar pathway with the production of coenzyme Q10 and cholesterol. There's a branch point off of that pathway that produces MK4. Every form of vitamin K that we ingest, including vitamin K1 and MK7, is converted to MK4 in our bodies and in tissues throughout the body, including bone, intestines, pancreas, our arteries, brain, testes, breasts, in all of those tissues. The predominant form of vitamin K that accumulates is the MK4 form, pointing to its wide-ranging health benefits. And in bone health, we have clinical trials, showing that as well. The only tissue in which, or the only organ in which MK4 is not the predominant form of vitamin K is the liver, and the predominant form in the liver is vitamin K1. What we see also in irritable bowel disease patients is many other nutritional deficiencies: vitamin D, iron, selenium, and you can just go on down the list. So glucocorticoid-induced osteoporosis treatment options, there's a meta-analysis, and we do have some good data now showing that some medications are helpful at reducing fractures and increasing bone mineral density. Actually, let me rephrase that. Vertebral fractures have been reported. There's benefit from these medications for reducing vertebral fracture risk. Hip fracture risk, however, has not been reported. And so we do have that at least for vertebral fractures, and non-vertebral fractures that aren't aren't hip fractures like a wrist or forearm fracture. So what we know essentially is that increasing in terms of lumbar bone mineral density and vertebral fracture efficacy, teriparatide, it's a PTH, parathyroid hormone analog. Forteo is the name of that medication, is better than denosumab or Prolia, also known as Xgeva, which are better than the bisphosphonates like risedronate or alendronate, which is Fosamax. So there are some good data here in terms of helping patients, helping doctors also choose an appropriate medication. MK4 has been used in multiple clinical trials on prednisone or glucocorticoid-induced bone loss in patients even with kidney failure or chronic kidney disease on dialysis. Here you have a clinical trial. Well, they took 45 milligrams per day, and these were all patients with kidney diseases, IgA nephropathy or minimal change disease. They took the 45 milligrams per day of MK4 in divided doses with prednisolone for 4 weeks, and then they tapered down the prednisolone. And the outcome, the lumbar bone mineral density at baseline and 10 weeks after starting prednisolone, and what you see is that MK4 was preserved the bone mineral density. There's no significant change, whereas in those just taking the glucocorticoid group, the lumbar bone mineral density significantly decreased. The second clinical trial, also with the mixed patient populations in terms of diagnoses, but all with kidney diseases. It was for 2 years. They took either control group, only the glucocorticoid, or they took vitamin D or MK4 or vitamin D plus MK4. That's this group down here, or all participants. And again, all participants took prednisolone. And what we see is that the control group significantly lost bone mineral density over that time period. In any other group, any supplementing with vitamin D, the MK4, or the combination, there was no significant change. So preserved bone density, but bone density was maintained in people taking all those nutrients. However, what you saw in the people just taking the vitamin D is that the serum calcium was significantly increased, but the MK4 plus the D, or the MK4 alone, prevented that increase in serum calcium. So there's a beneficial effect there as well. Acid blocking medications, I mentioned those briefly above. And what happened is they create nutritional deficiencies. They reduce the absorption of nutrients, and they also contribute to the gut dysbiosis, which is a very bad combination when it comes to bone health and overall health. So proton pump inhibitors, I mentioned Protonix, Prilosec, Nexium, Prevacid, those are all the trade names. The other category, the histamine 2 receptor antagonists, Tagamet, Zantac, Pepcid, half of those prescriptions, as I mentioned, are just for that acid reflux. And one of the earliest studies was in 2006, published in JAMA. Just 1 year, a little more over 1 year of PPI use is associated with a 44% increased risk of fractures. 1 year of H2RA use was associated with a 23% increased risk of fractures. 4 years of cumulative PPI use, 60% increased risk of fractures. But when their analysis restricted just to patients with acid reflux and not taking the medication for other indications, long-term PPI therapy was linked to a 350% almost increase of fracture risk. Patients with GERD taking H2RA category of acid blocking, that was not significantly associated with increased fracture risk. In some patients, you can see there with the confidence interval, did experience that. But overall, as a group, no significant increase in fracture risk. So if somebody has to be on an acid blocking medication for acid reflux, it appears that the histamine 2 receptor antagonist category of those medications are safer to use. What about osteoimmunology? So chronic inflammation leads to bone destruction, both directly and indirectly. So you have some what are called osteoclastogenic cytokines. So those are molecules that the immune system produces that increase osteoclast activity. They're pro-inflammatory. They increase inflammation. So tumor necrosis factor alpha, you can see the whole list here. Not only do they increase the number of osteoclasts, but they increase how long the osteoclasts survive for, how long they can do their damage. And tumor necrosis factor alpha in particular is a very potent inducer of bone resorption. Those then the opposite side of that, because there's pro-inflammatory molecules and then there are anti-inflammatory molecules, that things that we want to try and increase, like interferon alpha, interferon beta, try and rebalance that inflammation response. So anti-tumor necrosis alpha therapy with infliximab, a medication used for different inflammatory conditions, including irritable bowel disease. There were some clinical trials on it, 18 to 22 months, and that actually increased the bone mineral density by 8%, plus or minus 7% compared to controls. No difference in hip bone mineral density, but lumbar bone mineral density did significantly improve. And at the end of the study, though, there was no difference in the treatment group compared to the control group in patients taking prednisone. So if they're just on the infliximab and with Crohn's disease, and then they got a significant increase in bone mineral density of the lumbar spine. But if they're on prednisone as well, they did not get that benefit. So be aware of that also. There's interaction with other medications, and the prednisone is canceling out the bone benefits of the infliximab in this situation. The second clinical trial, also with Crohn's disease, taking prednisone, and the mean lumbar bone density did increase in this study, even patients who are on prednisone by 2.4%. And the femoral neck bone mineral density down here increased by 2.6%. So these are a little bit contradictory, these results of these clinical trials, and hopefully more research is being conducted. The bottom line is that this gives me hope that if somebody is in infliximab, even if they are taking prednisone, they may see an improvement in bone mineral density. We hope they will, but I'm also not a believer of just doing one thing in a condition like this that is so dangerous, where we know that multiple factors and multiple etiologies are involved in causing this problem. I want to really come and approach this in many different directions, and pharmacotherapy, the use of medications when appropriate, is just one of those areas. So what happens here is this chronic inflammation in the gut and the dysbiosis in the gut can cause leaky gut. So here on the far left, or on the far right, you see the intestinal barrier here, and there's no space between these cells that are indicated here in the pink. They're called tight junctions. Nothing can really pass through. In fact, molecules greater than, very small, technically greater than 15 angstroms, cannot get through this barrier. But what happens when you have chronic inflammation and dysbiosis and all these pro-inflammatory molecules, and also these waste products being produced by the infectious bacteria or the unhealthy bacteria, it causes holes, you can see here, to appear in these tight junctions. And so different, larger size molecules can pass through here. Those cytokines, those inflammatory molecules, also can pass through here. Small bits of food that maybe is not totally digested can pass through here. Most of the immune system in the body is clustered around the intestines. It's in this submucosal layer here. It's called the gut-associated lymph tissue, and it activates that immune system response to try and attack what it's seeing as these foreign invaders, and then gets into the bloodstream, these different molecules, these antibodies, and these cytokines, and it travels to the bone, or then it has all those effects that I discussed earlier and leads to bone loss and increased fracture risk. What are we losing when we lose the healthy gut bacteria and we have dysbiosis? Well, healthy gut microbiome and healthy gut bacteria produce vitamins for us. They produce B vitamins like vitamin B6 and vitamin B1 and 2 and 3 and folic acid. They produce short-term fatty acids like butyrate, propionate. Those are anti-inflammatory fatty acids that also help heal the lining of the gut and are also help with bone health. They've been shown to be helpful in terms of bone mineral density and overall bone health. So it's this balance, restoring the balance is really important. So the microbiome effects on the bone, when you look at mouse studies, as I mentioned, vitamins derived from gut microbes and produced in the gut are, quote, potential regulators of bone matrix quality. And the gut microbiome, those healthy gut bacterial, is associated with many metabolic bone processes. So in dysbiosis, I talked a lot about this. I'm not going to belabor this point, but mounting evidence is linking the change of that gut microbiome to pathophysiology of osteoporosis, but not just in the gut. There's evidence now showing that bone loss in the jaw, alveolar bone loss, is also linked to gut dysbiosis. And that contributes to periodontitis, alveolar bone loss, and of course, the osteoporosis of the other bones that we're talking about. So probiotics, might be simple just to say, we'll take a probiotic. Many people's minds, I think, go there. But the research, I think, is a little too premature. There have been studies that have been done both with a single strain of a bacteria and multi-strain probiotics. Both have been shown to have the same results. All the studies are in animals. There are no human studies yet. And the bottom line is that bone density was improved. There's one of the studies in the 10-week-old mice. They were given both a single strain and a multi-strain probiotic. It prevented bone loss, it prevented gut permeability, it prevented systemic inflammation, and both increased bone mass in mice who had, these are female mice who had estrogen replete mice. So I do think that it's important to understand that you can take a probiotic. It's very healthy. But I think that there are other things that are important, just as important, or even more important to do. Things we know destroy the microbiome: not getting enough sleep or poor sleep, insomnia, sleep apnea, treating those, exercising, making sure you're exercising. That actually helps the microbiome and helps heal the gut lining. Eating a Mediterranean style diet, which is a plant forward diet. And of course, taking probiotics. All of those move the microbiome back into the healthy direction. I talked about short chain fatty acids for bone, so I'm not going to belabor this point much. Mediterranean diet, that's MD, Mediterranean diet and irritable bowel disease. What we found is that higher adherence of a Mediterranean diet is associated with a 21% decrease in hip fracture risk and a higher bone mineral density of the lumbar spine, whole body, and trochanter. And people who adhere to that diet to a greater degree have greater amounts of healthy bacteria and greater amounts of short chain fatty acids, both of which I've talked about. And by the way, irritable bowel disease patients, they have this dysbiosis. They have less bacterial diversity. They have low numbers of these Bacteroides and Firmicutes bacterial species. And what we see is that the Mediterranean diet helps to rebalance that gut microbiome and increases diversity in irritable bowel disease and other patients. So a healthy Mediterranean dietary pattern, these are all the mechanisms of action by which it helps, these different components of it, like yogurt, fruits, vegetables, fiber. These are the mechanisms by which they help. But in terms of everyday life, it has its pyramid, food pyramid. And what you really want to do is emphasize whole fresh fruits and grains and vegetables and lean proteins. Avoid and minimize highly processed foods or ultra processed foods. And I'll be speaking again for this to this group about. I don't know exactly when the date is, but it's coming up. But ultra processed foods and the consumption of ultra processed foods is associated with osteoporosis now. And essentially, the Mediterranean diet is the opposite of the standard American diet. So low in processed meats, lower in red meats. And you can see here, to learn how to transition into this way, to eat this way can take some time, because it is the opposite of how most people are eating in this country. But one thing that's not talked about enough, and when it comes to the Mediterranean diet, is not just eating more fruits and vegetables, which we know are healthy for us, but getting enough protein. As people get older, they tend not to get enough protein, and the amount of protein they get is insufficient to maintain muscle and bone mass. There's an anabolic resistance that develops as people get older, meaning they need more protein to get that bone, that muscle building effect of the protein. And in fact, many people, as they get older, don't even eat the minimum USRDA for protein, which is too low to maintain healthy muscle. your body weight in pounds, if you take your body weight in pounds and multiply it by 0.6, that's my recommendation for the minimum number of grams of protein you should be consuming a day. Most people I talk to are not getting that much when they actually calculate how much they're getting. There are other recommendations that go higher than that. I just am recommending a minimum of 0.6 based on the research and the clinical trials. And there is a consensus statement for protein intake and its relationship to bone that came out of the International Osteoporosis Foundation and European societies. And basically, the amount of protein that somebody consumes, that alone can account for 2 to 4% of bone mineral density. Remember, I said, there are 180 to 200 proteins in bone, in addition to collagen, which is the main structural component of bone. So making sure you're getting enough protein is crucial. And the recommendation also, if getting enough protein is important, because eating enough protein has also been associated with a decrease reduction in all-cause mortality. That's decrease of death from any cause, including osteoporosis. And to transition into eating this way, I developed a system that I've taught to thousands of people at this point that walks them through transitioning into eating this way over 4, 6, 8 weeks, whatever's comfortable. I call it 3 steps to eating healthier for life. And it's a way to eat to promote your health for the rest of your life. And I have people focus on trying to get 30 grams of dietary fiber per day, because that's going to be found in the whole foods, those whole fruits and vegetables that we need. And then also the protein requirement based on their body weight and how to transition into that. There are handouts here in the URL on my website and instructions on how to do that if you would like. Here's a summary of my recommendations. It's under-recognized, it's under-screened for. I think it's a lot more bigger problem than is recognized, because most people who should be getting screened are not. And then GI conditions, gastrointestinal conditions are common, very common causes of secondary osteoporosis. And those underlying mechanisms, multifactorial, inflammation, leaky gut, nutritional deficiencies, dysbiosis, all contributing to that. And then as well, looking at fracture risk, the risks of falls, not getting enough protein, not doing resistance exercise to build muscle mass, to improve balance, reduce the risk of falling. That's also important. So my recommendations are what's called the 4 R's. I did not invent that, but the 4 R's: remove anything that's causing a problem, rebalance the gut microbiome, reinoculate the gut with the healthy bacteria, and then repair the gut lining. So that's the 4 R's for gastrointestinal health. And then the Mediterranean diet with ample fiber and protein, identify and supplement with nutrients to correct deficiencies, protect against medication-induced bone loss, meaning, identify medications that could be putting you at risk and seeing if those could be modified or changed to safer options. Thank you for your time. And if there's time for questions, and that's an option, I would love to take some questions.
Thank you so much. Yes, there are time for questions. Let's see here. One of the questions was about supplementation with vitamin K. And I know that there's these different forms and there's these different effects. So how would you put this simply for someone who's like, okay, I'm in a drugstore trying to buy a supplement. What should I be using?
So if you're in a drugstore trying to buy one of these supplements, they don't exist in the clinical trial dose. I'm 20 years ago, I brought MK4 into this country, the first country to do it in the clinical trial dose of 45 milligrams per day. Still the only company in the country with the MK4 clinical trial dose with vitamin D3 combination. So what to ask, the questions to ask when you're identifying any nutrients in any bone support products is, have the nutrients been shown to improve bone density? So if you look at the other form of MK4, MK7, the manufacturers make a lot of claims on their websites. It has a longer half-life, so it stays around longer. It's more bioavailable, meaning it's absorbed better than the MK4. It changes a molecular marker, therefore it's better. But nowhere do they say that it improves bone density. And nowhere do they say that it maintains bone strength as indicated by fewer fractures in clinical trials, because that's never been shown. In fact, every clinical trial with MK7 that has been done has shown that at best, MK7 only slows down how fast women with postmenopausal osteoporosis lose bone. It doesn't stop it. It doesn't reverse it. And in one clinical trial, the women lost bone at the hip faster, those women who are taking the MK7 versus the control group. And there are no clinical trials taking MK7 with any medication-induced bone loss. And there are no fracture outcomes, no clinical trials with fracture outcomes. So the MK4, the only way to get it is not in a drugstore. It's online. Part of the challenge with the drugstores is that most people are shopping on price point. The MK7 is cheaper, and there's an educational component to the MK4, like I've shared with you today, that most people don't know. And the marketing for the MK7 is very sophisticated, and people don't know to ask the questions, the clinically relevant question, which is, has it been shown to reduce fractures? And the only form and the only dose that's been shown to do that is MK4 45 milligrams per day. And, look, and so much so that after 20 years of doing this, my company guarantees it. We have 3 versions of the product. On our website, you can look at them. They're also available on other online platforms, but on our website, we guarantee that within 6 months of taking any of our 3 versions of our bone support product, your bone density will stabilize or improve. But more importantly, if somebody breaks a bone, we'll refund their money for all qualifying purchases between their bone density tests because of the strength of the research. So I hope I've answered that question well enough.
Yeah, that's excellent. Any other questions, please put them in the chat. I have a question for you, as a vitamin D researcher. How do you feel about this movement to no longer test for vitamin D and that insurance companies aren't going to be covering it?
I think it's a
And
mistake.
how do we handle it?
Well, unfortunately, people are going to have to pay out of pocket if the insurance company is not going to do it. I mean, people can routinely supplement. I mean, you could take, if most people taking 2,000 IUs of vitamin D per day has been shown to get them within that range of 30 to 44 for about nanograms per milliliter for bone health. There are some populations where I can imagine it would continue to be justified to test them, like people with some of these, with IBD, for example, where malnutrition is well documented. I would be shocked and saddened, frankly, if insurance stopped covering vitamin D testing and other nutrient testing for those patients. But in general, taking 2,000 IUs of vitamin D is going to get somebody into that range. There are some indications that, people with obesity or malabsorption issues, they need higher amounts than that. But that's my response to that. I mean, we're all stuck in the system where insurance is not covering, I think, a lot of things that have been shown to be very clinically effective.
Correct. And then, coupling that with all of your lifestyle recommendations, there are many lifestyle recommendations that you can give to kind of help support that too, right? Going outside, but then the use of sunscreen is always debated as well. So,
Well, part of the, even people in Phoenix and, that's where the study was done in the Southwest, there's a large percentage of people that are deficient in vitamin D or don't have enough. And part of that is, the cars we drive in have UV protected glass. We're wearing, covered up. We're not getting that sunlight. We're working indoors more than outdoor work in the past. We do have sunscreen on. And even in the wintertime, if you're in north latitude, if you're in the northern hemisphere in the winter, above, from California, like Santa Cruz east, if you're anywhere above that line, the sun isn't getting high enough in the sky to activate the vitamin D receptors in the skin, to activate the pre-vitamin D and create vitamin D. So there are a lot of reasons, and there's a good case for just wider spread supplementing. Not that everybody needs it, but that a lot of people do need it.
Okay, a quick question here. This will be our last one about collagen peptides and their effect on bone health. Is that something we should be taking?
So it's not my first line, but because we can produce collagen, our body can produce collagen from the amino acid precursors. And that's where I think getting protein from, or getting the peptides from food is best. I am a strong believer and advocate that dietary supplements should be used as the FDA approves them for, and as the FDA indicates, which is as a supplement to a healthy diet. So diet is always first in my book. And what we see, though, with collagen is, hydrolyzed collagen has, there have been a lot of clinical trials, and it has been shown to improve bone density. There are no outcomes with fractures. So that's when I'm evaluating the research. I really want to see fractures outcomes data. That's why I was very, my recommendations are very tailored and focused on that. And then everything else is, second line, maybe as indicated, if they want to supplement, it's also, collagen is great for skin and hair and nails, and clinical trials have shown that it improves skin hydration and reduces visible lines and wrinkles, for skin health as well. And collagen can be a good adjunct and a good addition if somebody wants to do it. But if the choice is, I'm either going to supplement with collagen or I'm going to improve my diet, I'm going to want them to improve their diet.
Well, we couldn't end on a more perfect note, and I completely agree. It's all about diet first. Thank you so much for your time, John. We really appreciate it.
Thank you.
Bye, everyone.